Welcome to this fabulous event that allows us to assess, share, compare knowledge and experiences about the management of the critical lung, those patients that are very frequent in the ICU and that many times are the reason for our specialty and regarding mechanical ventilation, respiratory failure, as well as pneumonia that we have at different altitudes. We come from Latin America, and precisely what we want is to be able to share that knowledge about the practices we have in managing our patients. This is a very important session where we will touch on topics about what to do and what not to do in a world health crisis, as well as inhaled antibiotics for respiratory infections, and the differences in pneumonia between sea level and the very high altitudes. So it's a pleasure to be able to introduce my two colleagues who will share this eighth session with me, organized by the Pan American and Iberic intensive care medicine, with a lot of interest, not only for the Andean zone, but for Asia, Africa, that has high altitudes. Many countries, either developed or developing countries, that want to be able to offer our patients a more personalized treatment that can give them a better progress. So I want to introduce my colleagues that will share this session. Dr. Alexandra Saranguro, specialized in critical and internal intensive medicine from the La Tacunga Hospital in Ecuador, as well as Dr. Luis Osorio, specialized in intensive care by the General University of Rio de Janeiro, and the AMIC, the Brazilian Intensive Care Medicine Association. And my pleasure as well. It's an honor to share this session in this World Lung Day. Without any further ado, and following the program, we will give the floor to my distinguished colleagues for the first topic in this very important session. We'll invite Dr. Saranguro, Alexandra Saranguro, so that you can share her screen, to talk about what should we do and not to do in a worldwide healthcare crisis. Dr. Saranguro, the floor is yours. Good afternoon. Yes, we see your screen and we hear you perfectly. I want to thank you all for the opportunity to be able to speak with you, as you mentioned, from Ecuador, from La Tacunga. And I will talk about what to do and what not to do in a health crisis. So first, I'm going to focus on what we should not do, part of the lessons that the pandemic left. And I think that if somebody would have mentioned what the pandemic would look like, perhaps we would not have believed it. We had faced H1N1 and SARS, and in many cases, we felt that we were prepared. We spent several years planning a pandemic that would look like the viruses that we already knew of, but we did not have any plan for face masks, massive scale tests in order to remain at home, politicized decisions that were devastating. So facing the future, we must prepare ourselves for much wider threats in the countries and organizations and hospitals. Everything related to health, I think that we need to have robust healthcare systems, response plans to pandemics, and adequate infrastructure to protect the population. The second thing that I believe we should not do is erode public trust and change weak evidence-based policies. If we remember, during the first few months of the pandemic, there was a lot of uncertainty on how to be able to face all of this. But I believe that now we have realized that the best thing is to adhere to the basic principles of critical care medicine, including the configuration or the setting of ventilators, the amount of sedation, intravenous fluids that we had been managing previously. An important part of this is not to have infodemics or excessive information. At some point, the majority of specialists looked at the existing literature on COVID. There were a lot of articles, at some point, even more than 25,000 that were available for the public. But many of these had concerning deficiencies in terms of the quality of the information to the treatment and the treatment modified as the pandemic moved forward. So infodemia increased exponentially in a very short period of time. And there was like a combination of scientific and technical information with rumors, manipulated data, false experts, incorrect information. And so clarity was difficult in terms of what information to choose. So our critical thinking has to prevail. We need to trust the baseline of critical care patients. We had prior studies that could be helpful to base ourselves on those for the treatment. The other thing is not to forget lessons learned and protect the vulnerable population. Hundreds of people every day in Latin America and also in other countries in Europe and Africa migrate. They abandon their families, their countries, and their destination is North America or Europe or other neighboring countries. So how can the health, as healthcare people, as this article mentions, we need to develop the necessary skills to be able to provide optimal care to this population that is normally young, that can contribute to the societies of the countries that they are living in. But sometimes they come from countries that have more considerable health issues. For example, infectious diseases, they are probably not adequately vaccinated. So all of these things have to be analyzed to be able to offer high quality services to these patients. When on occasions we don't share the same language between the patient, the family members, and the healthcare practitioners, it is important that centers have interpreters or translators so that we can have efficient intercultural communication that can strengthen the treatment or the complex decisions that we must make at times. That is also important. Sometimes at the hospital where I work, we have these interpreters that help us make decisions together with the family members. So what should we do? First of all, I think we need to have the adequate preparation, the strategy, and the needs we have when there are crises are focused on developing dynamic capacities in reforming organizational structures and also investing on the staff and also have leadership qualities. This last crisis showed us that we had deficiencies in those senses. In several articles, as you can see here, they show strategies, key strategies to prepare for the future. Many of these are by levels of intervention that health care systems require. What we all need to do, each one from the level where we work, we have to become more dynamic structures. We should not remain stiff. We have to learn to be flexible and able to prepare for continuous learning. And that is going to strengthen the institutions and will allow the healthcare staff to anticipate and to recover from future systemic threats. And how can we achieve this? Some of the things we can do are to adopt strategic, coordinated foci that are evidence-based, that improve planning and service provision in the future. We can also craft plans, long-term plans for crises based on resiliency, dynamic management, and pre-crises models. And in the intensive care setting, we have to have quality indicators. We need to develop and strengthen dynamic capacities, for example, detection to be able to predict. If we have difficulties to hold all of the patients that these health crises generate, we need to act quickly so that we can provide fast, rapid responses. We also need transformation based on continuous improvement activities, communication, and cooperation, so that we can work in an interdisciplinary fashion to be able to face these problems better. Another thing is effective communication. And this is seen as something fundamental for care safety and for the patient's well-being. Another important thing is scientific literacy. It is not enough to have all of the supplies, the ventilators, everything we have at each ICU in the hospitals, but we need to open up spaces to be able to improve the knowledge of the people that make up the teams, provide proactive training to improve alerts on outbreaks of infectious diseases. We have to have these spaces, either face-to-face or online. They can be established using technology and becoming partners with technology. After the pandemic, there has been an acceleration of the adoption of technology in many different aspects of our life. In intensive care therapies, we have teleworking, we have medical consultations that can be provided online. As a hospital, we still have teleconsultation in one of the services. And it also helps us with virtual simulation, which is recommendable to provide scenarios that are more realistic to avoid infections from an inadequate use and to also reduce costs in facilities. Now that AI is a means to establish areas for learning, and these can be personalized for those that use these technologies. Mental health is also important. During the pandemic, the importance of mental health was highlighted. Social distancing, confinement, a fear of infection had significant impact in the health of people. So as healthcare staff, I think it's very important to look at this part. We need to improve health policies and safety policies at the workplace to balance out workloads and mitigate burnout. Also, to provide PPE, personal protective equipment, to foster culture that promotes teamwork, cooperation, the recognition of the efforts, support, and autonomy that each one of the members of the team has. So what should we know about mechanical ventilation? As I had mentioned, besides having mechanical ventilators, the pandemic showed us that we need comprehensive tactics that increase the staff that is adequately trained, safe spaces for treatment, and that there are additional equipment that could be part of our service. Many of the studies that appeared back in those times were presented from Latin America with all of the difficulties that we have. Access to ICU beds was also difficult. These are limited. The possibilities of hiring additional staff and naturally high quality assessments that were more complicated. So as you can see, historically, the Berlin definition is the last thing we have to be able to classify, with many problems because we don't have a perfect method that will allow us to confirm or rule out something definitively because of the heterogeneity that characterizes ARDS with all of the clinical presentations, responses to treatment. So all of this variability is an important challenge for all of us. So it becomes more relevant after the pandemic. We have to look for personalized medicine that includes the different phenotypes that can exist in ARDS. As you can see in the images, these are some of the guidelines that we could follow, these different research lines. Personalization that allows higher pulmonary protection as a line of research. We need to understand the pathogenesis of ARDS to be able to stratify each patient, even though some of these therapies that you can see here can be applied to all of the patients. It's necessary to identify that some of these could be more beneficial for certain subgroups that can be biologically different. So information is rapidly available, so we need to improve all of our research lines so that they can be applied, especially in countries with limited resources. And my take-home message is, one is the importance of training the medical and nursing staff, the physical therapists that are working in each one of the intensive care units. I think that we all have to learn about mechanical ventilation, look at all of the physiological variables that apply to mechanical ventilation. We need to set ventilators with personalized settings, because there's high heterogeneity of the syndrome. So this personalization is fundamental for the treatment of ARDS. Thank you very much for your attention. And I am available if there are any questions. Thank you very much. Thank you, Doctor. We will look forward to the questions at the end of all the presentations. Now we invite Dr. Luis Osorio. Please start to share your screen so that you can share your presentation on inhalatory antibiotics for severe respiratory infections, on the use of inhaled antibiotics that is very common right now. Dr. Osorio, the microphone is yours.
Use. We can use lower doses. We have higher antibiotic concentration at infection sites, mainly in alveoli. And we can reduce induction of bacterial resistance. It's a very important point when we talk about infection control. When we use inhaled antibiotics in intensive care units, the main indications are ventilator-associated pneumonia treatment as adjuvant, rescue, or empirical. VAT treatment, there is no recommendation to this use, but may be used in specific colonized patients. And ventilator association pneumonia prevention. That's a very important point of study. In this one, inhaled amikacin to prevent ventilator association pneumonia, the results show us an important and significant reduce in incidence of ventilator-associated pneumonia when you use 3 days amikacin inhalatory at the moment of the mechanical ventilation initiation. And this effect is until 28 days. When we not use inhaled antibiotics, obviously, if the pneumonia due it to no sensitive bacteria, and we cannot, instead of intravenous therapy, we cannot use inhalation therapy only. Which antibiotics can be used by inhalation? Based on pharmacokinetic, concentration-dependent antibiotics are the choice. In this group, polymyxin B and aminoglycosides are the best used. In aminoglycosides, it seems to have a slight advantage in the use of amikacin. But a recent Chinese meta-analysis shows us no advantage over any antibiotics used. How to use inhaled antibiotics? It's a very important point because the wrong use cause loss of effect. And the first point is to define the nebulizer type. There are many, but the most useful are vibrating max, ultrasonic, and jet. The vibrating max causes minimal interference on mechanical ventilation and low residual volumes. The ultrasonic can cause medication rating with loss of effects. And the jet causes significant interference on mechanical ventilation in a high residual volume. So the best choice is using vibrating max. Another point is where we use the nebulizer. We have to put it on inspiratory limb of ventilatory circuit in a distance between 15 to 4 centimeters of the Y-piece. And during inhalation, we cannot use any kind of filter, mainly bacteriological filters. This way, the last one, is the right way to use nebulizer in mechanical ventilation. We have to change mechanical ventilation settings during inhaled antibiotic use. We have to use control modes, low inspiratory flow, prolonged inspiratory time, a protective tidal volume, and of course setting alarms. At the end of inhalation, we return previous settings. Of course, we can have side effects of inhaled antibiotics, but they are transient and less 2% of cases. We can have medication loss during procedure, we can have tachycardia, hemodynamic instability, bronchospasms, transient hypoxemia, and need to increase sedation. As I told, transient, and rarely we have to take an action. Clinical studies results show us conflicting results, with no difference in overall mortality, but with increased bacteriological cure and possible preventive effect. That's a very enthusiastic point of study to prevent ventilatory-associated pneumonia. The European Society of Microbiology Infectious Disease does not recommend the use, but the American Thoracic Society and Infectious Disease Society of America accept the use as adjuvant or rescue therapy in ventilatory-associated pneumonia due to multi-drug resistance bacteria. Take-home message about best practice: we have to pay attention on indications. We have to pay attention on organization. That means staff training, the nebulizer, the circuit setup, ventilatory settings, gas condition, that means no filter use, and safety and monitoring. The future perspectives: electronically synchronized nebulization with mechanical ventilation, nebulization with heliox, intratracheal spray, that is a bronchoscopic procedure, and developing specific medications to be used by nebulization. We think that these are important points that are under studies and may optimize the delivery of antibiotics by inhalation. Thank you for your attention. Thank you.
Thank you very much, Dr. Osorio. That was a great presentation also. So now going on our schedule, I'm going to talk about pneumonia in high altitude. Me parece muy interesante la pregunta que muchas veces colegas nos
The
hacen.
question that colleagues pose to us is very interesting. I live in La Paz, as I'm going to show you, and I work in a city that is at 4,150 meters above sea level. There is barometric hypoxia. It exists, and some colleagues who live by the coast in Latin America think that since we are exposed to chronic hypoxia, we in altitude, we could die more easily as the pneumonia evolves. So, or the opposite, since we are exposed to chronic hypoxia, we tolerate hypoxia much better as a complication of pneumonia, and we die less, not associated with acute respiratory distress. So it is important to try to answer this question. I have no disclosures. This is the place where my country is located and my city, La Paz, in South America. And as you know, it shares most of its territory with the Andes. 1/3 of the territory of my country is on this cordillera, on this very interesting mountain range. You see the llamas there. So this is my city, La Paz, and we use a cable car for transportation, and I work at the top, which was previously called the dormitory city, because the people who came from the rural areas came to work, came to La Paz, and then they would go back to sleep at El Alto, which is higher up. It's a young city. But it has hospitals, schools, and institutions that have rendered it independent as a city. So where does everything start? It starts with barometric pressure. At sea level, it is 760 millimeters of mercury, and this creates a cascade of oxygen so that it can diffuse to the mitochondria and produce oxidative phosphorylation for energy production, right? And what happens in El Alto at 4,150 meters above sea level? Well, the oxygen inspiratory pressure is not 150. I refer to inspiratory pressure. I'm not referring to FiO2, since the FiO2 is 21% anywhere in the world. However, inspiratory pressure is directly dependent on barometric pressure. It is much lower, it's 60%. So the oxygen inspiratory pressure is 85 millimeters of mercury as compared to the 150 millimeters of mercury at sea level. And it's worth saying that we work, we live, we reproduce with 60% only of inspiratory oxygen pressure. And this is important because when people who live at the coast come to our town because of tourism or for medical congresses, they feel breathless. They feel that there is no air, and if they exercise, they may develop an acute complication, acute lung edema, or brain edema caused by high altitude. So everything has to do with inspiratory oxygen pressure. And how important is this in terms of altitude medicine? Look at this list. We can realize that Peru has the highest city, 5,130 meters above sea level. However, it has only 50 to 70,000 inhabitants. Unlike El Alto, although we are 4,150 above sea level, our population is 1 million. So it makes it the most important natural laboratory for the study of altitude medicine. And this table is interesting because we can see other cities, either in Bolivia, El Alto, Potosí, Oruro, La Paz in Bolivia, or in Peru, Juliaca, Puno, Cusco, Huancayo, also Ecuador, Tulcan, Quito, Colombia, and Bogota, high up. So in Latin America, there are many cities that are at high altitude. And what is the importance of this learning of chronic hypoxia? Because don't forget that the common denominator of our patients in shock is tissue hypoxia, right? So well, let's see what happens with pneumonia. This is the classification of the International Society of Mountain Medicine. For me, this is appropriate because it allows to classify altitude levels as we rise in terms of meters above sea levels. Changes in blood gases are more pronounced. These are blood gases at 4,150 meters above sea level, and we can see that the pH tends to be alkali, 7.4, and PaO2 of 58, and you can see that we cannot follow the gasometric definition that mentions acute hypoxia failure under 60 millimeters of mercury. So in that regard, we would always be in respiratory failure, and it is not what really happens in practice. We have adapted to operate at lower pressure and saturation levels. CO2, because of this hypoxia, is lower because indeed what we find is hyperventilation. We exhale more CO2 as we search for oxygen, as we can call it, as we seek for oxygen, and bicarbonate is also lower. It's not 24 or 22, but 20. And saturation is sufficient at around 91%. And in fact, I would also like to share the blood gas values that we use in pregnant women who live at these altitudes because of progesterone stimulus. They have alkalotic values, 7.452, CO2 not even 26, but rather 24. And why is this important? Because if I have a pregnant woman who permanently resides in high altitude, I need to look for these parameters in order to establish the settings of the ventilator and find the acid-base balance. So what we have done is adjust according to the Berlin formula, and at 4,150 meters, we consider mild distress less than 180, moderate under 120, and severe under 60. And this is the conversion factor of 60. So therefore, a PaFiO2 of 190 for us is normal, but it would be moderate distress for other altitude levels, right? So we need to look for every hospital, every city according to the altitude level, and work on the gasometry values based on that. This was a study published in 2020 about the evolution of patients with respiratory distress before the pandemic. And what did we find? This is the answer. The evolution is similar. The level of altitude doesn't influence mortality. What influences mortality is the patient's condition, the Apache 2, that is the functional acute status, comorbidities, and age. Those will the patients who tend to die. This is before the pandemic, and this is an article published in the Latin American Association of Chest Medicine in 3 levels of altitude at 2,600 meters above sea level, whereas in Peru at 3,100, at El Alto at 4,150. And we found that the course of COVID patients is similar. It's not that they would lie more or less at a higher altitude. You can review this article, or you can write to me and I will share the article with you. And the message of this article is precisely that altitude doesn't kill, and it doesn't protect either, at least when we talk about critically ill patients. This is another article published in 2021 where we showed that patients with lower levels of erythropoietin die more because they lose the regulatory mechanism, the compensatory mechanism that allows us to adapt to chronic hypoxia. These are 2 equally important papers, one by Dr. Molano from Bogota, describing the phenotypes at altitude and also discussing high flow oxygen therapy about the success indicator, which is not so much the ROX index as such, but rather respiratory rate. A respiratory rate of less than 30 is associated with a better course in altitude. Why? Because our heart rate is precisely different. And this is an article about neutrophil and lymphocyte and PCR and CRP regarding prediction of mortality. And we confirmed with this article published this year at the beginning in Frontiers in Physiology, where we showed that the inflammatory variables, CRP, procalcitonin, even predict a worse course when they remain high or when they rise as compared to the patients who normalize these values. What do I mean to say? That we don't have to focus so much as people tend on do it on the PiO2 or FiO2. Every individual is different, but we live in adjusted groups depending on the altitude. This is another article. We didn't publish it, but as you can see at the top, death of patients with pneumonia due to SARS-CoV-2 during COVID, which was really a milestone for all intensivists, is similar to other altitudes. And finally, I present this article, which I think is the most representative of the work that we do. We managed to identify that oxygen saturation constantly measured in the ICU between 89 and 93 is sufficient for the patient to evolve favorably. We know that hypoxemia is deleterious, but if we offer values above 93 at El Alto, where we saturate at 91, 92%, it's enough. Hyperoxemia is also deleterious. It may produce free radicals biotrauma, atelectasias, and pulmonary and systemic complications. There is a systemic pro-inflammatory state. And in that regard, we need to look, and this is a message to wrap up, we need to look for the main values to which we need to adjust at different levels of altitude, because I repeat, hyperoxemia, thinking that the patient will saturate like at sea level at 97, 98 is not the adequate concept for the patients in altitude. And you can review the article, which is consistent with what we described, the normal blood gases between 85 and 91 in order to offer better prognosis for our patients. And here I show the characteristics of the sample, 140 patients, and defining objectives for every level of altitude can be associated with a better survival. And to conclude about this very important part of altitude, which I imagine is very interesting for you, remember that beyond 1,500 meters above sea level, there are also changes. There are already changes in blood gases. Altitude doesn't kill or protect, but the evolution of the disease depends on the severity of the picture and the characteristics of the patient. And the purpose of this talk is precisely that, to offer ideally personalized treatment, even in relation to the site where the individual lives. Thank you very much for your attention, and you can see my contact information. If you want me to share your articles, send me a comment if you wish. Thank you very much. Now we are going to go to questions and answers with the people who have had an opportunity to make presentations regarding these wonderful topics. There is a question about mechanical ventilation. If you would consider in obese patients initiating with high PEEP. Alexandra or Luis, would you like to answer this question? Alexandra, please. You also live at 2,200 in La Tacunga. Yes, we also live in altitude on the Sierra in Ecuador. Yes, we are crisscrossed by many mountains, as I showed you. In fact, in obese patients, there are several studies in which working on principles of anesthesia and ventilating with high PEEP. However, it will depend also on the individual patient, if the patient has ARDS, if mechanical ventilation was initiated because of other reasons that don't have to do with primarily lung pathology. In fact, if it is a patient with ARDS, we try to personalize mechanical ventilation, estimating settings based on predicted weight, looking at ventilation mechanics, the driving pressure, or determining compliance. And using all those parameters, then we titrate PEEP, trying to remain within a protective mechanical ventilation mode. In many cases of ARDS in obese patients, we have pronated many of those patients. During COVID, indeed, we had the largest number of patients who were obese. So yes, we pronate these patients. We calculate according to the ventilation mechanics, and we also approach the need for PEEP based on all those observations. We have not always used high PEEP. If the patient is not on mechanical ventilation due to a pulmonary cause, anyway, we maintain moderate to moderate PEEP in order to ventilate and reduce the probability of atelectasis. So what we do is to work very hard with physical therapy before once we start with weaning. So that's what we do. Wonderful. If you are to give a number, what is moderate PEEP? 7, 8. It's that range, in fact. Wonderful. Dr. Osorio, your experience. What is important in obese patients is to make sure that the lung maintains an adequate size. That is our main concern. The pulmonary mechanics refers to the chest wall and the difficulty of ventilating a patient with a chest wall that is increased, so to speak. As we just heard, we need to personalize mechanical ventilation, and increasingly we use PEEPs in values that are not as high, because the possibility of inducing a lesion because of excess of PEEP is also something that exists. So when we use the definition of compliance or tidal volume based on predicted weight, it is precisely to try to homogenize a ventilation mechanics. Of course, mechanical ventilation of a patient with morbid obesity is much more complex than in a patient who has normal weight. But you may imagine that PEEP values of 8, 10 are most of the times extremely well tolerated and beneficial, even in an obese patient. Wonderful, then. So 7 to 10 is the value. It's the initial suggestion for moderate PEEP. Okay. I have a question regarding Alexandra's topic. How could you select the most appropriate literature in these cases of pandemic, the H1N1? It was difficult to find literature, but it was very useful for all the countries when we started to read about COVID. So what is your recommendation? We hope that there will never again be a pandemic, that we know that with our population density in some countries, it is almost unavoidable to face new epidemics or pandemics in the coming years. So how can we select the literature? What are your recommendations to select the literature that can tell us how to manage critical patients? Let us hope that it will not happen again, but if we ever have to face a new pandemic, as I say, I believe that it is very important to be prepared and to know, be prepared with all the knowledge regarding the pathophysiology. That is very important. It's a very important starting point, having also a trained team, each knowing the pathophysiology of the diseases that we have to manage every day in the intensive care units. It is very difficult in some cases to know, even more so if those publications appear in prestigious journals. It is more difficult, but as you know, at this time, there are also several algorithms that teach us and help us identify and analyze each of the articles, be them reviews or original articles. And they allow us to understand how to select this information. The literature also advises that apart from considering where the origin of those articles, we should also consider the number of patients so that we can put together the information on the pathophysiology and the new information that begins to emerge. Wonderful. Thank you, Alexandra. There is a question for Luis here. Any antibiotic in which the infusion time is much more important, its concentration is much more important. For example, carbapenems or beta-lactams, which we know have a higher action when we infuse them over a prolonged period of time. Those antibiotics would not be ideal to deliver through nebulization. The main studies have to do with aminoglycosides and polymyxin. Another point, and something that comes up frequently, is we need to respect the sensitivity of the bacteria using when we use antibiotics in inhalation therapy. If we give inhalation therapy, the bacterium will not respond. So the sensitivity will depend on the concentration of the antibiotic, and it will also depend on the time of treatment, similar to the treatment time used when we use venous infusions. These are concepts that have to do with the therapy. When we talk about prevention, then the concept is somewhat different. We provide a shorter antibiotic time, and the main studies have to do with the use of amikacin. despite the fact that polymyxin and ceftazidime have already been studied. But what we see in terms of trend is practically almost a restricted use of amikacin, tobramycin, or polymyxin B. Wonderful. Now there are questions in the chat. We still have 9 minutes. What are the oxygen objectives in patients with distress and patients who have been born in a high altitude and then are transferred to sea level? And another related question, so patients who come from the sea level to altitude and have distress, respiratory distress, what values should we apply to those patients? It is difficult to demonstrate this in critically ill patients because we know the treatment in patients that are born in altitude, but what happens the other way around if there is pneumonia in a patient who lives in altitude but goes to the coast? I don't have specific data of respiratory failure due to pneumonia, but there is a clinical case that we published a week ago in Medical Reports. This was a patient, a young patient, a 28-year-old who had a head injury in Ecuador, in a parish that is close to Riobamba. And the parish is at 3,600 meters above sea level, and Riobamba is at 2,400, right, Alexandra? And this patient was brought down because of the level of complexity and was managed by Dr. Maldonado, who is a friend of ours in Ecuador, and he did all the management, intubation. There were hemorrhagic contusions, and when they did the transcranial Doppler on the second day, managing the patient with in accordance with all the recommendations, they found vasodilation and hyperemia, and the patient had a CO2 value of 38 millimeters of mercury, normal for the coast, but the patient was not a resident of the coast. So Dr. Maldonado very reasonably remembered the values that we published. So he hyperventilates a patient until he brought him to a PCO2 value of 26 millimeters of mercury, and hyperemia went away. So a patient in altitude comes down to be treated, is treated with lower values and developed brain hyperemia. What do I mean to say? That we are adapted to the place where we live. I live at 4,150 meters above sea level. If I go to Lima, which is 60 meters above sea level, and I have an accident, I should be treated with my values, the values from the place where I live. That is the example, because we can subject a patient to risk like hyperemia or bleeding if we manage the patient with values from an area where he does not live. We have published this, but of course it is difficult to recruit patients, but these sessions are good to communicate and share these ideas and do collaborative work and develop research networks. But that is a very important case, precisely because it tells of the importance of what the question asks. If a person comes from the coast and comes to altitude and suffers an accident, I need to manage that patient with the values of the coast. But if it is the other way around, with values that we apply in altitude. So the question had to do with distress. I have to manage with levels from the area where the patient comes from. It's not found in the literature yet, or it's not applied, but we are describing it. For Luis, in low-income countries, we only have parenteral antibiotics. Can they be used through the as inhalation, or you need anyways a solution for nebulization? Very important, a very important question, because the just right treatment is important. I can use aminoglycosides, tobramycin, and amikacin, the same injectable solutions. Why? The concentration is small. Their concentration is small. If it were a very high concentration during nebulization, what would happen is that a lot of medication would be lost. What What changes here are the doses and the application interval. Normally, not always, but for example, amikacin, we infuse once a day. And by nebulization, normally it is done every 8 hours, adjusting the dosing. But both amikacin as well as tobramycin can be used. The same solution can be used for polymyxin. And other antibiotics might need more specific adjustments in the form so that they can be used by the inhalation route. Wonderful. Another question, Dr. Viruez, you said saturation of no more than 93%. However, at sea level, that was the target. So the question is about lactate. Was lactate also considered as a marker of improvement? Yes, the objective of studies that were published in New England from Colombia were not to waste oxygen if at altitude, if our altitude if I use or seek saturations, because it is a constant way to monitor the patient of 96 or 98, I'm pilfering oxygen. Yeah, the patient may survive a complication, but I am exposing him to risks of free radicals, superoxide, and barotrauma. It's misusing oxygen. If a patient needs, for example, vancomycin, needs a gram, and if I give 1.5, I'm giving too much. The same happens here. In terms of lactate, lactate is the same regardless of the altitude. But yes, it can be used as a target of treatment in case of hypoperfusion and anaerobe metabolism as in other cases. That doesn't change. It doesn't mean that in altitude we live in anaerobiosis, but we have the mechanisms we have evolved and are adapted to be more efficient in managing whatever little oxygen we have. I think that those are all the questions, the most relevant questions, and I am very thankful as a moderator of this session. I wish to thank you. A big thank you for Brazil, for Alexandra. Would you like to say some final words? Yes, I'd like to thank you for your attention. It has been a very interesting session, in fact, and I'd like to ask you for your thank you for your questions. Thank you so much. Dr. Osorio, please. I wish to thank you for this opportunity to participate. I am available. If you need questions, you can send them by email. And it was my pleasure to participate with the two of you. Despite the fact that I am the only one who lives by the seaside. Thank you very much. So, dear colleagues, our embrace to all the audience. We have come to the end of this session just on time. I also believe that these are the sessions that enable us to get to know each other, open up and ask many questions. Nobody has the absolute truth, so we need to continue to research and come closer to the truth. Thank you to this tribuna as well, and we'll see you soon.